Female neonate born to 21-year-old G2P1 had jaundice for 8 hours of life. The neonates are red blood cell type is A positive, while mother's RBC type is O positive. The mother's anti-A antibody titer is elevated. A screen for feto-maternal bleed was negative. A direct cum test is weakly positive. The infant hemoglobin and total bilirubin are 10.6 and 7 respectively. The erythrocyte glucose 6-phosphate is normal. Sickle cell test is negative. Peripheral blood smear shows normocytic normochromic RBC, nucleated RBC, and reticulocyte. What is the most likely diagnosis in this patient? So this patient have ABO incompatibility. Okay, this patient have ABO incompatibility that is causing them to have a weak, a direct cum test positivity. Let's see. Remember, how do we make use of this in usually in any pregnant woman? They will give G1 like this kind of thing. It's G2 P1 means G is gravida, means how many time the patient is pregnant, even no matter how many times there was a term delivery or it was abortion. So we have to remember how many times the patient was pregnant. So it was this patient's second delivery or second child. P1 means patient had already delivered a child that is more than 20 weeks old. So you can so the right is at P1, and still the patient is carrying one more baby, that is another baby. Okay, so this is how we make use of it. G2 P1 is gravida 2 para 1. So here the patient is having the newborn is having A positive and mother is having O positive. So this is clearly, you can see both have same rhesus factor. So and the mother is O positive. So this cannot be RH incompatibility syndrome. Or patient also had normal G6 glucose 6 phosphate. This cannot be the answer. The physiologic jaundice does not have increased total bilirubin. It just have increased unconjugated bilirubin and total bilirubin, you can see. And the sickle cell usually presents after the 6 months, because until then the fetal hemoglobin is working and it doesn't cause sickling. Okay, it present usually after 6 months. So let's discuss this question. Here you can see there are a couple of blood types we have to remember. Blood groups are usually classified into ABO and RH or rhesus. So blood group A have antigens on them. The RBC of blood group A, they have antigens on them, and that is antigen A, and antibodies in their plasma is anti-B antibodies, and they are IgM. So IgM does not cross any placental barriers. Okay, so whenever a patient If the mother was A positive or B positive, and the child was O negative, so there won't be any antibody. It cannot happen, but if there was, so, and IgM cannot cross the placental barrier, and this can never happen in ABO classification. And it is mainly when there is a O positive mom which have IgG antibodies. This can cross the placenta and can destroy the neonate's RBC. You can see here the patient is having B blood group, they have B antigen and they have antibodies against anti-A. While O blood group, they don't have any antigens on them and they can produce anti-A and anti-B antibodies. Usually they are IgG, but they can produce IgM. Well, rhesus factor, this is usually a protein on the surface of RBC, so there will be IgG antibodies against them. Rh factor, they have antigens on the Rh positive, so there will be no antibodies. But if the patient was exposed to Rh antigen during the first delivery or any kind of placental abruption, so they produced any kind the antibodies against Rh factor, and that is usually IgG. And in subsequent pregnancy, mother can pass these antibodies to neonate or her child, and that can cause erythroblastosis fetalis or fetal death. Okay, and so here we have to remember two types of disease that is related to blood group disorders, or we can call it hemolytic disease of fetus or newborn. It's usually known as erythroblastosis fetalis. The Rh hemolytic disease is when Rh negative mom or pregnant patient had a Rh positive fetus. During the first pregnancy, patient was exposed to fetal blood during the delivery and causes formation of maternal anti-D IgG. But in subsequent pregnancy, the anti-D IgG crosses over to the placenta and attacks the fetal and newborn RBC, causing hemolysis. And this can present as hydrophytalis, jaundice shortly after the birth, and kernicterus. The unconjugated bilirubin going into the brain is called kernicterus. How do we treat or prevent this kind of scenario? We can prevent by giving anti-D IgG, or we can give early postpartum maternal anti-G IgG for the mother if there was a we suspect they had a postpartum hemorrhage. Okay, and in ABO hemolytic disease, usually the type of the mother's blood group is O, and if she's having a baby, that is type A and B fetus. So in this, there is a pre-existing mother has a anti-A or anti-B IgG antibodies that crosses the placenta and attacks, and this is mild hemolysis, and this causes mild jaundice in the neonate within 24 hours of the birth. We treat them via phototherapy, or we can give exchange transfusion.
Thanks for watching. Please give a thumbs up and subscribe for more.